Welcome to the Center for Esophageal and Gastric Surgery at the University of Washington. Thanks for coming to visit us today. My colleagues and I have put together a center that specializes in the treatment of esophageal and gastric disorders. And today we're going to talk a little bit about gastroesophageal reflux and the surgical treatment of that, which you're here for today. We look forward to providing you some information in the next few minutes that will help you in understanding the disease that you or the disorder you may have and the treatment options, and if you decide to have surgery, how that will go and what you can expect from those procedures. So our team includes a lot of people, some of which you will meet, some are working behind the scenes to provide excellent care for you. Of course, you will meet our surgeons and their trainees that work under them, their residents, fellows, and sometimes medical students. Be assured that the surgeons that you will have taking care of you will be coordinating all the care both in and outside of the operating room, giving you the best treatment possible. But you also meet our nurses, nurse practitioners, medical assistants. You've already interacted probably with some of our intake staff and people who will assure that this process goes as smoothly as we can make it and give you the best care possible. So let's talk a little bit about gastroesophageal reflux. Gastroesophageal reflux is actually something that every single person walking around on the face of this earth has every day. It's just a matter of how much. When you have a lot of reflux daily, it starts to become symptomatic and you need treatment for it. That's when we start to call it gastroesophageal reflux disease, but it's not something that some people have or don't have. Now, how does it work? Now, we generally think of something called the lower esophageal sphincter as the barrier to preventing acid and contents from your stomach from refluxing up into the esophagus and beyond. Now, this is not a true sphincter, but a lot of different aspects that are going in to controlling the reflux and keeping it in the stomach. You'll hear us talk about a hiatal hernia or your sphincter pressure or the motility of your esophagus and stomach. These are all things that contribute to your body's ability to prevent reflux from occurring. And if we need to do an operation, to some extent, things we are trying to address, or at least taking into account when we try to help you. Now let's talk about the symptoms and manifestations of GERD. The most common is heartburn, but not everyone experiences typical heartburn. You can have regurgitation of fluid and food up into the throat. You can have a sour taste in your mouth. As you move up the esophagus, you can get a hoarse voice or a chronic cough. Maybe that reflux goes into your lungs and you get asthma or pulmonary diseases such as pneumonia or inflammation and fibrosis of the lungs. There's a whole slew of manifestations that reflux can cause, and we really seek to understand what these manifestations are in each individual patient to determine the best treatment for them, and even whether reflux is a major driver of that symptom. There may be other complications that you will hear us talk about. Esophagitis, which is inflammation of the esophagus. Barrett's esophagus, which is a change in the lining of the esophagus that can be a precursor to cancer of the esophagus. Lung diseases and so forth are common complications of gastroesophageal reflux and are sometimes reasons that we need to do surgical therapy. We're here to talk about treatment. Obviously, you're in a surgeon's office to talk about potential surgical treatment, but for completeness sake, let's talk about all the things that one can do. Certainly there's diet and lifestyle modifications, trying to keep your weight at a normal range. Eating smaller, meals more frequently can be of assistance. Avoiding things like chocolate, caffeine, alcohol, they are stimulants for reflux, and avoiding them can help people with their reflux. As far as lifestyle, you can avoid tight-fitting clothes around your waist that can increase the pressure and promote reflux. Try not to eat a meal within 2 or 3 hours of going to bed. Quitting smoking would be another example of positive change. And a lot of people who have reflux at night will elevate the head of their bed to use gravity to prevent reflux. Besides those diet and lifestyle modifications, medications are usually a big part of the frontline treatment. You'll see a lot of them advertised and in the drugstores. The main class of medications used are proton pump inhibitors. They go by the names omeprazole or Prilosec. They go by lansoprazole or Nexium. You'll hear there are a lot of different types of medications. They all are in the category of proton pump inhibitors, and they're the mainstay, and really should be the first line therapy and the only line therapy for most people with gastroesophageal reflux disease. We only consider surgical intervention for those patients whose symptoms aren't controlled or they have a disease complication from reflux that is going to benefit from surgery. So what is surgery? Let's talk about the main type of surgery for reflux, and that is a fundoplication. A fundoplication is when we take the stomach, the upper part of the stomach, and wrap it around the esophagus. And what we're essentially trying to do is create a one-way flap valve for the esophagus. A one-way flap valve so that food goes down when we swallow, but acid and other contents of the stomach don't reflux back up. We are not trying to increase the pressure around the esophagus and create a restriction to it. But you may feel a little bit of those symptoms, and we'll get into the side effects a little later. In addition, we will usually repair a hiatal hernia, which is often present in most patients with gastroesophageal reflux that requires surgery. A hiatal hernia is a hole in the diaphragm that the esophagus normally goes through, and when it widens and lets the stomach go back up into through the diaphragm into the chest, that's a hiatal hernia. And what that does is it weakens and stretches the normal gastroesophageal reflux valve, the lower esophageal sphincter valve, to promote more reflux. So we fix that at the same time as we create the fundoplication. So what can you expect from surgical treatment? Now, you should not expect to have no reflux ever for the rest of your life. As I mentioned earlier, reflux is something that every person experiences every day. What you can expect if you have surgery is that we have found that you have an extraordinary amount of reflux, and our intent is to try to take you from a lot of reflux down to a fairly normal amount of reflux. In doing so, the vast majority of people will find their symptoms, their daily symptoms, disappear. Now, this is a very dynamic area. The diaphragm contracts thousands of times a day to help us breathe. We're swallowing many times a day. And so that area, as tight as we make it, can loosen over time. And some people will experience a little bit more reflux over time. Now, the good news is most people, the vast majority of people, have normal amounts of reflux for 10, 20 years and beyond, despite what you might read in the lay press. At least those patients operated on at the University of Washington. Now, occasionally, patients will develop some breakthrough reflux that we will want to treat, or their doctors will want to treat, with a little bit of medication. That we don't see as a complete failure, and usually that 10 or 15% of patients are much better controlled with that combination of medicine and their surgery than they were with medicine alone before surgery. It is very unusual. About 3% of patients will come back and require some sort of surgical intervention to correct a failure of their fundoplication if it was performed here at the University of Washington. If you feel like you're having increasing symptoms of reflux in the future, we would like to see you back. We would like for you to call our Center for Esophageal and Gastric Surgery and allow us to evaluate you. Much of the time we find that there's something else going on, or there is something happening with your operation that we can easily correct. Either way, it's good for us to see you and try to make that assessment. So please contact us or your doctor to get a referral back to our center in the future if there are problems. Now, you would probably like to know what the complications of surgery are. Fortunately, at the University of Washington, we have tremendous experience, one of the largest experiences in the world with the treatment of gastroesophageal reflux. So those side effects and complications are going to be extremely rare. But let me list the things that could happen on a rare or occasional basis. With any operation, you can have bleeding. Now, we use special devices to control the blood vessels in this operation, and far less than 1% of patients will have any sort of bleeding complications that we may need to address at this operation. Another common complication of surgery in general is infection. Again here, extremely low rates of infection. Because we will be doing these operations for you laparoscopically, the incisions are small and very unlikely to get infected. And if they do, even if they do, it's usually a very minor treatment to manage since it's such a small incision. And the biggest things you worry about are deeper infections. Those are usually caused by injury to other organs, an injury to the esophagus, stomach, or surrounding organs. That's extremely unusual and almost unheard of at our institution, but is an inherent risk of this operation or ones like it. I like to emphasize side effects because the actual surgical complications are so rare. This is where we need to decide, and you need to know whether the risks or the side effects of surgery are worth it for you. And it's a major reason why I tell people that if medications are working for you and your symptoms are very well controlled, then surgery very well may not be for you. Our side effects are also much lower than you will find in most other centers. And you will read about these side effects if you go to the internet or look at literature about fundoplications and their side effects. So let's take them one by one. One is something called dysphagia, or that is the feeling when you swallow a food getting stuck in the esophagus. Now, we've created a new valve. It's a very good one-way valve, but sometimes it's not perfect. And you will feel with certain foods that food kind of gets hung up a little bit in the esophagus. Usually very easily managed by slowing down, taking smaller bites of food, washing things down well. Really common sense kind of things, and things frankly that most Americans need to do with their diet anyway. Now, in the first 4 to 6 weeks after surgery, you will notice a lot of swelling, or there will be a lot of swelling in and around your esophagus from the fundoplication. And we'll put you on a special diet where you start with liquids and gradually progress along back to solid foods so that we ensure you don't get anything stuck, because we don't want you to heave or vomit and tear apart everything we've just worked so hard to reconstruct. Usually by 4 to 6 weeks, this is resolved and you can pretty much be on whatever kind of diet you like. These operations are constructed to prevent reflux. Now, reflux, we typically think of the acid going up into your esophagus, but another form of reflux, if you think about it, is air refluxing up into the esophagus. We would call that a belch. So with this operation, it is more difficult to belch. Not usually impossible, but more difficult. Also, vomiting is a severe reflux episode of food, usually when you get sick from something you ate or a virus that you caught. You should know that viruses and food poisoning and these sorts of things do not require you to vomit in order to get better. You will get better, your body will fight that infection. Admittedly, we often feel better, when we vomit and we're feeling sick to our stomach. But you don't need to. And again, this difficulty, although not usually impossible, is a small, I think, price to pay for patients with severe GERD who usually have daily bothersome symptoms. Because of your inability or decreased ability to belch, you may feel a little bloated if you swallow a lot of air or eat too fast. We've all experienced this feeling, and if you belch or release that air, again, you may feel a little less bloated, and that might be a little more difficult after this operation. The final thing that people sometimes experience is slightly more frequent bowel movements and increased flatus, or air coming out the other end. Let me start with air coming out the other end. We all swallow a lot of air and then make some air through the bacteria in our GI tract. That's what comes out the other end. Now, if we belch a lot, that decreases the amount of air that's going down. So if you do belch a lot, you may notice that there's more air coming out below in the form of flatus. That is a side effect, and if it bothers you, usually modifiable by swallowing less air. People swallow air for a lot of different reasons. They eat too fast. They eat or drink carbonated beverages. They talk a lot when they're eating, or they have a little bit of a habit of swallowing their own saliva, which swallows some air and that sort of thing. So these things are modifiable if we pay attention to them. The fundoplication itself also slightly speeds the emptying of the stomach. Now, usually this does not have any negative effect on digestion, but you might find that your food and bowels move a little more frequently after this operation, but it's rarely a major problem and usually doesn't come in the form of diarrhea. Okay, so you've had your operation and you're waking up. What can you expect? Well, when you wake up in the recovery room, you'll usually have an oxygen mask while you're starting to come out of anesthesia and breathing to give you extra oxygen. You'll have an IV in your arm, dripping some IV fluids to make sure you stay well hydrated. You'll have some little devices on your legs. We call them leg squeezers. They're called SCDs, or sequential compression devices, that are essentially trying to keep the blood in your legs moving to prevent blood clots. And a nurse will come by every so often and check your vital signs, talk to you, explain what's going on. And usually you'll spend about 2, sometimes as much as 3 hours in the recovery room before you transition to your hospital bed. Essentially, we're waiting to make sure you're well out of anesthesia and going to be comfortable on the floor. Once you are starting to reach that point, a family will be able to come in to the recovery area and be with you in those later stages and escort you to your bed and the floor. Okay, so now you're on the floor. What do you need to do and what will you experience? Well, hopefully you should feel pretty well. You'll have a slight amount of pain from your incisions. You'll be a little groggy from your anesthesia, but you should be starting to become awake. And when you do, you should start to get active. There are some negative effects or potential negative effects of anesthesia. One of them is your lungs. Your lungs will have more secretions. Some of the little balloons in your lungs will start to compress and deflate. You need to get them re-expanded. So you'll be given what's called an incentive spirometer, which is a little plastic breathing tube that the nurses will show you how to use to help you re-expand your lungs. The other thing that will help that is to get up and start walking. We want you moving. That'll help not only with expanding your lungs, but also help prevent blood clots. And just generally, it's going to get you back to feeling more normal more quickly. Your family can certainly visit you while you're in your room. It could even stay overnight in a slightly comfortable cot that can be provided for your room if they so choose. And with all this, you should be able to be feeling ready to go home by the morning. Frankly, I think you'll feel well enough to go home that day, most of you. But since we don't want people to vomit and heave, sometimes people respond with those symptoms after anesthesia, and we want you here to be able to give you very quick-acting anti-nausea medication to prevent any complications of surgery. Frankly, most of you, again, won't need it and could go home quite quickly. So you should be able to go home by first thing in the morning. Now, when you're ready to go home, you should have a ride because you need to avoid driving for the next couple weeks until you're off pain medication and you're at a level of pain that will allow you to drive and operate a vehicle. You'll be given some pain medication to go home with, and we may adjust some of your medications. We will like you to crush all your medications or take them in a liquid form, and a pharmacist will help us manage that for you. If you have complicated medications, sometimes they may need to be changed, and we'll do that and help you communicate with your primary doctor to switch those back if necessary. You'll get information about your activity, which will be largely instructed by your pain. The only thing we don't want you to do is do any heavy lifting, things that you're using your abdominal muscles to do. We don't worry about the abdominal muscles, but that's a pretty good surrogate of contracting your diaphragm. We want you not to contract your diaphragm because of that hiatal hernia repair and the stitches in your diaphragm. We don't want to stress those in the first 6 weeks while they're healing and scarring down. A dietitian will see you before going home to reiterate our diet for the next few weeks, tell you the sort of the do's and don'ts as far as food choices as you gradually increase your diet. This, I think, will be quite easy for you. We all have a sense of when food is going down easily or not, and really there's going to be a heavy dose of common sense about what you're ready to eat, as long as you don't try to overdo it too quickly and go from liquids to dry bread or steak, for example. So all this should be explained to you by our team and the nurses staff, and you should feel ready to go home probably by 11 o'clock in the morning on the day after surgery. And you should really make arrangements with your friends and family to be available to pick you up at that time. So when you're home, when should you let us know if there are problems? Well, in the big picture, we want you to call whenever you feel uncomfortable. But let me give you some examples of things we'd like to know about. If you're not able to keep anything down, if you were the day before able to keep down liquids and semi-solid things, and now you're not able to drink or keep anything down, we need to know that. If you start having significant vomiting, that's something we want to know about. Occasionally people will eat too much and get something stuck and they know it, and then they're just going to have to force that back up. We want to avoid that with our diet, but if it happens, that's okay. But unstimulated vomiting is something we really need to know about. If there's increasing pain or bleeding from your incisions, redness around the incision more than a half an inch around, these are things we need to know about. If you have chest pain, shortness of breath, they could be signs of a lung or heart problem. Please let us know. If your abdomen becomes quite distended or full and you're feeling significant bloating, let us know. Your stomach may not be processing as fast as we want it yet. Finally, if you are having a lot of diarrhea, I'm talking going to the bathroom 4 to 6 times a day, please let us know that. There could be a sign of an infection or something else going on that we would like to know about. Also, if you have any dizziness or fainting when you stand up, they may be signs of dehydration. If you have any swelling or pain in your legs, especially your calves, let us know. Those could be signs of a blood clot. And we want to know about any signs of infections around your incisions. These will be unusual, but if you give a fever higher than 100.5 Fahrenheit, that's 37.8 Celsius, let us know. If you have shaking or chills as a sign of infection, let us know. If you have drainage from your wound, there will be a little bit of spotting, a little bit of tiny bit of fluid that you'll see on the dressings. That's fine. But if the incision gets red and angry and you're leaking a lot more fluid than I described, or there's increased pain and tenderness at that incision site, please call and let our nursing staff know. Again, in the first 6 weeks, remember, no heavy lifting, follow our diet, eat and drink very slowly and very frequently, and then finally, avoid narcotics as much as you can. We don't want you to suffer, and the narcotics are helpful, especially if you have enough pain and discomfort to the first few nights make it difficult to fall asleep. But for the most part, after the first couple days, you really shouldn't require much in the way of narcotics, and most of your pain should be controlled with Tylenol and NSAIDs like ibuprofen. If you're requiring a lot, please let us know. If you are on narcotic pain medications coming into surgery, please make sure you discuss that with your surgeon and nursing staff to make sure that they are aware and come up with a pain plan for you after surgery, as this may be a little more complex than normal. And finally, if any of these things I've asked you to call about, or you have any questions at all, please give us a call in one of these ways to let us know, either for non-urgent problems during the day or urgent problems at night. There's always someone here to address your problems and concerns and take excellent care of you. So again, thank you so much for visiting us here at the University of Washington Center for Esophageal and Gastric Surgery. We really look forward to taking care of you and helping you with your gastroesophageal reflux disease.